Hello, everyone. We will start with our launch in 2 minutes. We're so sorry to keep you waiting, but it's just some ceremonies are happening outside. As soon as it's done, Dr. Ahmad Assaf will launch our Vivity lens. Thank you.
Okay. Good afternoon, everybody. So I'm sorry for the delay. I'm going to share with you my experience with the Vivity lens as an extended depth of focus lens. According to the ECRS survey in 2021, they asked the surgeon what lens they implant at that time, and it comes that the extended depth of focus was the second in the row after the trifocal lens. So the most common premium lens now has been implanted since 2021. I'm sure this number is quite different nowadays. The extended depth of focus becomes the second. And they asked the same surgeon, what is the main concern regarding nighttime dysphotopsias in the absence of postoperative ametropia or a healthy ocular surface disease? What is concerned, which type of lens you are more concerned about nighttime dysphotopsias? Came that the trifocal lens carries a higher incidence of dysphotopsias compared to the other lenses like the monofocal plus, or the extended depth of focus. And when they asked the surgeon what kind of premium lens they are going or planning to implant in the near future, in the next 5 years, most of the surgeons, 66% of the surgeons responded that they will implant the extended range of vision multifocal lens or the extended depth of focus lens. So, in another separative study, they asked the surgeon why the surgeons are reluctant to implant a premium lens or presbyopia correcting lens. And it comes that the visual disturbance is the main obstacle preventing the surgeon from implanting this type of technologies for their patients. So we need something new. As you know that the trifocal lenses or the multifocal lens, or let's say the bifocal lenses, they have two versions, the refractive optics lens or the diffractive optic lens. And whatever the refractive or the diffractive carries high incidence of the nighttime dysphotopsias. Why is that? Because this is back to the basics of the optics. So the monofocal lens, as you can see, while if the eye is focusing to a far object, the light rays from this far object will be focused on the fovea, on the retina. And this is 100% of the light rays has been focused on the single spot on the retina or the fovea. But with the trifocal or multifocal lenses, this is a different story, because the light rays is being splitted inside the eye into two different foci, one for distance and another focus for near in the mid-vitreal cavity. So Splitting the light rays means splitting of the light energy, and this will cause reduction of the contrast sensitivity. This is the first issue with the trifocal lenses, that we have reduced contrast sensitivity because the light energy inside the eye has been divided between the distance and near foci. And it's not only this issue, but the near focus will cast another blurred image superimposing the focus image on the fovea, and this is the source of halo. So with the trifocal or multifocal lenses that splits the light rays inside the eye, we have reduced contrastivity as well as we have halos, because of the image of the near focus will cause superimposed another blurred image on the distal focus. And again, you cannot cheat physics. With the diffractive optics, you have loss of the light energy. Not only splitting the light rays, but you have lost light energy. Sorry. As you can see here, with the diffractive optics, if you are trying to attempt to split the light rays on distance and near foci, you still have some other unuseful foci, as you can see in the right side of the screen. So you have at least 19% of the light energy is lost inside the eye. So we have reduced contrastivity because of the splitting of the light rays. We have loss of the light energy inside the eye, and we have another issue of the nighttime halos and glare because of the superimposing of the images from the distance and near foci. And these are the main issues for the trifocal lenses or multifocal lenses that prevent surgeons like us from implanting this kind of lenses inside our patient's eye. So we need something new. We need new concept. We need something that at least improve the depth perception of those patients without too much nighttime dysphotopsis. And here it comes the X-wave technology or wavefront shaping with the Alcon-Vivity lens. The lens utilizes 100% of the light rays. It based on the concept of wavefront shaping. What is wavefront? What is wavefront? Wavefront is the imaginary line representing the corresponding photons that synchronize or vibrate in the same frequency at a time. And the light ray is the imaginary line perpendicular on the wavefront. So this is the source of the light, and when we go further away from the source of the light rays becomes parallel, as you can see here. So the light rays start in divergent because the wavefront is divergent, then further away from the source of the light rays becomes parallel. And if we intersect these light rays with the positive lens, again, we are going to reshape the wavefront and bring the light rays back to focus again. So here, what is the concept of wavefront shaping? Here with the wavefront or the light rays, as you can see, while putting a positive lens, now the wavefront is being shaped so the light rays will be focused on a single spot. If we increase the thickness of the lens in the central part, we are going to reshape further the wavefront. But how we are going to do that? By delaying some of the photons passing through the central part of the lens in comparison to those photons passing through the mid-periphery of the lens. And this will cause shaping of the wavefront because some of the light rays will be, some of the wavefront or some of the photons will be delayed further in comparison to the other photons in the mid-periphery. That's why we can shift the wavefront this way by increasing the thickness of the lens, at least in the central part. Only 1 micron of the lens increased thickness can produce this. But this will cause, of course, extend the depth of focus of the lens, but may compromise the visual acuity for distance, because now we have some sort of myopic shift. So again, we can, after shifting, we can reshape again the wavefront or stretch the wavefront by change the curvature of the central part of this elevated plateau on the central part of the lens to bring those photons back again toward the fovea. So this is the main 2 concepts of the wavefront shaping or the wavefront stretching of the Vivity lens. We are going to shift the wavefront further inside the mid-vitreal cavity to induce some myopic shift, but in order not to compromise the distant vision, this very central part of the wavefront will be pushed again or stretched back again toward the fovea not to compromise the distant vision, at least with a very small pupil. So how we can do this? By just doing an elevation in the central part of the optic of the lens. It's just a plateau of 2.2 millimeter in diameter, 1 micron thick, and this will cause delay of the photons. Again, this will cause shifting of the wavefront, and we can stretch it by decrease the curvature of this plateau in the central part by reducing the curvature. So this is animation to show that this is the crystalline lens, and with the implantation of the Vivity lens, again here, you can see that the light rays, we can stretch the focus, and we can shift it again slightly central, slightly inside the mid-vitreal cavity, so to enhance the depth of focus without compromising the visual acuity for distance. So again, this is the eye trace. The eye trace is the barometer to trace the light rays inside the patient eye. This is one of my patients, and as you can see, this very central part of the pupil is blue in color. That means that this is slightly hyperopic or slightly shifted toward behind the fovea. But again, away from from this central part of the blue color, you can see green and yellow. That means that this is a myopic. So this is a combination between a myopic and hyperopic refraction through the central part of the pupil, and this is the main concept. As you can see here, if you are looking this part, I'm not sure if the laser pointer is working, it's not working. As you can see in the central part, we have a myopic shift, but the very central part of the wavefront is just focused on the fovea, or maybe slightly behind the fovea in a form of hyperopic shift. And again, with the OPD scan, you can see again with the OPD here, this is an annulus of shifting of the wavefront in the mid-vitreal cavity. This is a myopic shift, while the central part is just focused on the fovea. So we have excellent visual acuity. Theoretical, we have excellent visual acuity for distance, and again, we have extended depth of focus thanks to this annulus of yellow and green color surrounding the blue dot. So lab studies showed that the Vivity lens produce halos quite similar to the Acrysof IQ, the single monofocal lens that we all know, and much less compared to the other presbyopia correcting lenses in the market. And this is the defocus curve of the Vivity lens in comparison to the IQ lens. The defocus curve of the Vivity lens in the blue, while the IQ lens in the gray, you can see we have extension of the defocus curve for the Vivity lens. So we can enjoy, the patient can enjoy decent functional vision for distance, even if there is post-operative ametropia up to 1 or 1.25 diopters of ametropic surprise after the implantation of this lens. But again, this is not only the advantage of the extended depth of focus, that it's more forgiving regards to the biometry issue in comparison to the other trifocal lenses. We can, because of this extended depth of focus, we can enjoy distant vision, quite clear distant vision, as well as intermediate vision, working in front of computers, iPads, and mobile phones as well. Near vision, we can have a decent functional near vision up to 40 centimeters with the implantation of this lens. And again, this is the depth of focus, objective measurement of the depth of focus with the eye trace. It measures the depth of focus of this lens of 1.67 diopters, so actually it's quite decent depth of focus that most of us can rely on this amount of depth of focus to work in front of computers and dealing with the mobile phones. So this is an example for the 49-year-old teacher, and the correct biometry for this lady was 25 in the right eye, 25.5 in the left eye, but because of the availability of the lenses was limited at that time, so we could implant only 0.5 diopter less in each eye. And I discussed with the patient that we might need a laser vision correction to correct the potential post-operative ametropia after implantation of this lens, and she agreed to do this after the implantation of the Vivity lens. And again, as you can see, this is after implantation of the lens. She had almost spherical equivalent of 0.5 diopters in the right eye, 0.5 diopters in the left eye, as expected, but the patient was very reluctant to do the post-operative laser vision correction because she was quite happy with the refractive results of this lens. Why? Because, again, we mentioned that this lens has a broad landing zone. The depth of focus is much broader compared to the monofocal lens, so it's more forgiving regarding the ametropic surprise, especially in the hyperopic side, compared to the monofocal lenses. And again, this patient still enjoyed the depth of focus, binocular depth of focus of more than 1.5 diopters. And you can see this is the modulation transfer function. As long as this blue line is not touching the red square, that means that the patient enjoyed excellent quality of vision after implantation of this lens. And I'd like to test my patient even with the OPD. You can see this is the point spread function after implantation of the lens. And you can see the contrastivity curve is quite similar to the normal values of the age group patients. And this is the higher order abrasion of the eye after implantation of the Vivity lens within the normal. You can see the total RMS, the total coma, the total trefoil, the total spherical abrasion of the eye within the normal values of the normal eye. So the clinical experience here, we conducted a study by implanting 72 eyes implanted with a Vivity lens, and we had a statistical significant better intermediate visual acuity compared to the IQ lens as well as with the fore and near vision. Regarding the contrastivity was very comparable in photopic and mesopic contrastivity was very comparable to the IQ lens. With the contrastivity with glare, there is slight reduction of the contrastivity with the Vivity lens in the high cycle per degree, in the 6 and 12 cycle per degree, but it was not statistical significant difference. So this is another example for the patient that she is 6 years old and she is a grandmother. She used to have a lot of night driving for her daughter. And she asked for cataract surgery with premium IOL. So she asked in particular for multifocal lenses, but because of a lot of night driving, I was very reluctant to implant trifocal lens for this kind of patient. Although, as you can see, the topography was quite good, or she was a good candidate for the trifocal lens, but because of the lifestyle of this patient, I was reluctant to implant a trifocal lens. And I implanted her extended depth of focus, and as you can see, she can read. She had to extend her arm slightly, but she can read, and you can see the speed of the reading of this patient is quite well. So again, this is the point spread function, the contrastivity, the higher order abrasion of this patient after implantation of the Vivity lens. In another large study conducted by Alcon, included 757 eyes implanted with the Vivity lens. This is the overall cohort to study the visual outcomes of the Vivity lens. And you can see the study parameters included the corrected and uncorrected visual acuity, the visual disturbances, especially at night, the degree of spectacle independence, and patient satisfaction. And this is the total cohort. Most of the eye had mean uncorrected visual acuity of 20/20 for corrected as well as uncorrected visual acuity. And the patient reported spectacle independence not only in bright conditions but also in dim light. Most of the patient could read or could deal with the menus in bright as well as in dim light. And the patient satisfaction was very high 3 to 6 months after implantation. 60% of the patient could read newspaper without reading spectacles, as you can see in this graph. And the most important, there was no too much complaint regarding the nighttime dysphotopsis. 91 or 92% of these patients reported there is no halos at all, and glare as well as starburst. So what about the monovision? So can we implant the monovision strategy for this patient in order to improve the reading ability of those patients without extending the arm? So again, the study included monovision, and the criteria for monovision is one eye is emetropia or 0.5 diopters within the emetropia, while the other eye should be toward the myopic side by at least 0.5 diopters of myopic side compared to the emetropic eye. And again, the uncorrected visual acuity for distance showed no statistical significant difference compared to the overall cohort, the non-monovision group. But here, the near visual acuity was significantly better compared to the non-monovision group. So we can improve the reading ability for these patients by employing the monovision without compromising the distance visual acuity. Again, the spectacle independence independence were almost the same compared to the overall cohort, especially in the dim condition as well as in the bright conditions. And the patients, 67% of the patients could read newspaper compared to this 59% of the patients with the non-monovision group, and they could read as well the subtitles on the TV, which is a fine vision requirements without a distance spectacle as well. So we can improve the reading ability for these patients without compromising the distant vision. And again, there is no much complaint compared to the non-monovision group. Again, because of the monovision, we were somehow skeptical regards the visual quality, especially at dim light, and there was too much complaints in terms of halos, glare, or star bursts. So again, this is one of my patients, 45 years old. This patient reported some partial amblyopia in the left side. So I employed the monovision strategy for this patient. As you can see, the left eye was slightly myopic compared to the right side. And this patient asked for refractive surgery. He has some nuclear sclerosis. So again, I implanted the target emmetropia in the right side, as you can see, and slightly myopic shift in the left side, and the patient could read without spectacles for distance, for reading a newspaper and small print of Jaeger 2 or Jaeger 1 binocularly without compromising the distant vision. And you can see objectively the contrastivity again, point spread function, and the higher order aberration of this patient was quite within the normal range. So what about post-myopic laser vision correction? Can we implant this lens in post-laser vision correction, especially the myopic? Again, we can study retrospectively the eyes implanted with the Vivity lens after laser vision correction, especially for myopia, and there was no too much statistical significant difference compared to the virgin corneas. Again, the degree of spectacle independence was quite similar to the virgin corneas and the patient satisfaction, and there was no complaints in terms of halos, glare, and star burst. Dry eye, it's very common in our area. What about the performance of the Vivity lens in terms of dry eye or ocular surface disease? As you know, that dry eye affects the biometry, so we might not have very accurate biometry in the presence of ocular surface disease. And dry eye affect the visual performance not only of the trifocal lens, but also as well the monofocal lenses. And the visual performance with dry eye, somehow the visual outcomes might be affected after implantation or with the monofocal lens. So we studied the visual performance of the Vivity lens in the presence of dry eye disease or ocular surface disease. As you can see, although the presence of some emmetropia after implantation of these eyes with dry eye, which is quite acceptable because we know that dry eye affect the key readings and the biometry, so we might have some post-operative emmetropia. Still, most of the patient can enjoy 20/20 Snellen vision without glasses, even in the presence of slight emmetropic surprises because of the dry eye. And the degree of spectacle independence, as you can see, most of the patients with the dry eye can read or at arm's length and in the bright and dim condition, and can, of course, drive without distance spectacles. And again, the visual quality was quite acceptable for this patient, even in the presence of dry eye. Again, this is another patient, 69 years old, with type A personality, and this patient asked for cataract surgery, and she was quite interested for the spectacle independence, and she had right Bell's palsy. So this patient has severe dry eye, as you can see, and this is tear film analysis, and you can see the breakup time in the 7 seconds, non-invasive breakup time, 7 seconds in both eyes. So this is not a case for trifocal lens. This is not a case for premium lens unless we have to address this dry eye. Because the dry eye is a chronic condition, and I was not sure that the patient will compliant for treatment of dry eye long life. So again, this is the pentacam. You can see slight irregularities because of not of the corneal issue, but only because of the ocular surface disease. So I aggressively treated her dry eye before moving forward for the cataract surgery. And as you can see, after implantation of the lens with the Vivity lens, the patient could read without glasses. She had a binocular uncorrected visual acuity of Jaeger 3, and the quality of vision, even in the presence of dry eye, was quite acceptable quite similar to the monofocal lens like the Acrysof IQ lens. So again, this lens is forgiving not only for the ametropic surprises with dry eye, but the quality of vision of this lens provide, even in the presence of dry eye, is quite similar to the monofocal lens. And as you can see, the patient was pretty happy, and this is the type A personality. You can see from her face. This is not easy patient to satisfy. Again, glaucoma. What about glaucoma? As you know that, we know that with glaucoma, there is decreased the contrastivity, and after implantation of the Vivity lens, we had quite similar condition like the monofocal lens. Why? Although the glaucoma decreased the contrastivity, and the higher the mean deviation with the glaucoma, with the field analysis, we have the worse contrastivity. So don't forget that this lens does not reduce the contrastivity. The Vivity lens behaves quite similar to the monofocal lens. It's not like the trifocal lenses. So again, with the trifocal lens, we have splitting of the light rays, we have loss of the light energy. So we are stressing already stressed optical system with the glaucoma. But with the Vivity lens, we use 100% of the light rays, quite similar to the monofocal lens. We are not inducing any more stress in the already stressed optic nerve or the ganglion cell layer. So that's why we can implant the Vivity lens, although it's contraindicated with the trifocal lenses, but we can implant Vivity lens in patients with glaucoma. So this is the next generation extended depth of focus lens that's filling the gap between the monofocal and the trifocal lens. It has the merits of monofocal lens with less strict selection criteria, less biometry issues compared to the trifocal lens, and excellent quality of vision compared to the monofocal lens, and it has some decent visual acuity for distance and intermediate and near, quite similar to the trifocal lens. So it fills the gap between the trifocals and monofocal lens, and this is my to-go lens for all of my presbyopia correcting lenses. Thank you very much for your attention. Questions, please? Any questions? Yes, we have one question.
You have a question? All right. Well, first, thank you very much for the great talk. The question I have in my mind, I think it's the same question that everybody here has it in their minds. We spend a long time with the trifocal patients for counseling, and then still after the surgery, the first day, the patient will arrive and burst. So what's the difference between EDOF and trifocal in this aspect? That's one question. The other question is, if we follow the indications strictly, with the trifocal, we get 5 patients out of every 100 cataract cases we get. Apparently, you have more. Can you just expand on this, please? You have more on the EDOF. Can you expand more? Why do you have more cases in EDOF than in trifocal? Thank you.
Okay, regards your first question, the chair time with the patient is much less. We used to spend maybe hours before and after the surgery with the patient, trying to explain before the surgery, trying to explain or bring the expectations of the patient down to earth, that there might be some halos and glare, nighttime dysphotopsias, reduced contrastivity, and the patient should accept this, and trying to explain to the patient that this will take some time for neural adaptation, up to months, maybe years, until the patient gets used for this nighttime dysphotopsias. And even though after the surgery, the patient used to come every now and then, hey doctor, still I can see the halos. Hey doctor, still I cannot drive at night. Hey doctor, I'm not very satisfied. It will take more time. Should I wait more? How can I drive cars? I'm not very happy. I used to see better before doing this kind of surgeries with my own glasses. So we need to sit with the patient for hours trying to explain to the patient that it will take too much time until it resolves or go away. And sometimes we have to explant those kind of lenses. Also, it's minor percentage of those patients we have to explant some of these lenses because of the failure of the neural adaptation. With the introduction of the EDOF lens, because we have too much less nighttime dysphotopsis, I have to admit we have some glare, yes, but it's not spontaneous reported. If you ask your patient about the glare, you can see, yeah, the patient will respond, yes, I can see some glare, but it's very acceptable for the patient. So I tend not to explain to the patient what is going to anticipate before the surgery. The chair time now with the patient is much less. It's very comparable to the monofocal lens. Okay, I'm going to do the surgery. You might expect some glare after the implantation. I will never mention halos because there is no diffractive optics for this kind of lenses. You might experience some glare after implantation of this lens. It will fade away 1 or 2 weeks, and then you will not notice this glare. And I didn't have to explant a single AVVT lens after implantation or introduction of this technology to my patients. So the chair time is much less before and after the surgery. It's quite comparable to the monofocal lens, and there is not too much headache that we used to experience with the presbyopia correcting lenses with the diffractive technology. So I'm not mentioned that this is a replacement for the trifocal technology or this presbyopia correcting lenses, but it adds to your practice. And this is the answer for your second question. So let's say out of 100 patients, we can implant 5 cases or 5 eyes with the trifocal lens, but we can implant instead to 95% with monofocal lens. You can implant at least 30% of those eyes with EDOF lens, so only the monofocal lens will take around 60%. So you can improve your practice. You can implant more presbyopia correcting lens. You can add value to your surgery. You can give your patient added value for free, just without compromising the visual acuity or visual quality for distance. So in addition to the presbyopia correcting lens, which has a very strict selection criteria, you should have a pristine eye, pristine cornea, intact macula, no dry eye, angle kappa should be within the normal values of 0.4 at least millimeters, the cord length. The pupil size, as you can see, we have a strict selection criteria for the presbyopia correcting lens with the diffractive technology, but this criteria is not very strict as for the EDOF lens. So with the introduction of this lens, this is not a replacement for the trifocal lens, but add to your value, add to your practice for your patients, so you can give more advantage for your patients in terms of reading abilities without glasses, at least. I would like to say that I will never promise my patients with the EDOF lens that you will be 100 spectral free. For reading small prints, they might use +1 diopters, reading glasses, from the pharmacies, the nearest pharmacies, but most of my patients are quite happy with the monovision, so they even do not use these reading spectacles for fine prints. And because of the modern lifestyle, we are counting more on the digital screens. So with the mobile phones, I used to tell my patients, you can go to the settings, make your fonts bold. You can enlarge your fonts a little bit, and you will be 100% spectral independence if you can adjust your digital screens for such lens. Okay, thank you. We have to finish. Thank you very much for your attendance.
Hopefully everyone's still awake. We would like to start the neuro-ophthalmology session. So I would like to ask Dr. Dana and Dr. Raed to have a seat here. And they can't hear? Yeah. So we'd like to start the neuro-ophthalmology session, please. Our first speaker will be Dr. Dana Behbehani, who has come here all the way from Canada, and she'll be here soon. She'll be coming soon. We would like to thank her for coming all this way and giving us her talk. So our first talk will be glucomatous versus non-glucomatous optic neuropathy.